especially Dr. Sagnik and Dr. Milan, and guidance of Praveen sir. So, thank you all for joining. So, we'll quickly revise today's topic, and the topic is MHCA. And as you all know, that it is the most important topic in forensic psychiatry and including the entire psychiatry curriculum as well. Be it theory, be it practical, somewhere or the other, this topic is going to come up in some way or the other, be it in emergency treatments, be it in admission sections, be it as a criticism, be when you talk about rights or other legal formalities. So it can come up as a full marks, 25 marks question, 20 marks question, as a short note on some of the sections like advanced directives, nominated representatives, or when you're presenting a long case or short case, the examiner can ask under what section would you like to admit it and what are the guardrails, safeguards of these sections. So considering that, that has been my choice for the first lecture because it is the most important and a number of times we struggle to remember the sections specifically. So now before we go into that, we'll just touch upon in short duration of time about how to write in theory exams because I believe that right now all the hard work is already done and it's not the time now for any more hard work, any more labor. In theory exams, we need to do smart work because here the most important thing is scoring marks and no need to show off your excess knowledge. So there is no need to do that. So you don't need to fill pages, you don't need to write many paragraphs to score marks. You need to work smartly so that whatever knowledge you have, whatever time you have, whatever questions they put, you can extract the maximum number of marks out of this. And we all know that theory is the basis of your passing or failing in MD, DNB exams. Practicals do not weigh as much as theory. And once if your theory marks are up, you can cover any mishappenings that are happen in practicals. So I want you to be interactive. The chat box is open. I want you to put in questions, queries, uh, so that we can solve the doubts as we go through the topic and each and everything is covered. So this is not a one-off lecture. You already know the topic. You already know a rough idea how to give theory exams. You must have given some mock exams or heard it from your seniors. So therefore, the purpose of this live lecture is that you can ask the questions right in there because we do not have time for that. So what I'll be covering in this 2 hours and a little more is that first we'll talk about writing theory paper for scoring marks, managing the types of questions and the time management, and then we'll cover the MHCA topics. We'll talk about we'll revise the entire topic and discuss what is usually asked, how it can come up in theory and practicals. We'll revise that. And lastly, we'll take up some questions, actual questions that have been asked in your exams. And we'll answer it in brief so that we know how to structure those answers. So now talking about theory papers. So in theory papers, you will face three sorts of questions. First, where you will get this facial expressions. Okay, I have a big brain. I have remembered this topic from head to foot. I know everything about this topic. So in theory one, part one paper, this could be a question on serotonin. So it could be a question on neurotransmitter serotonin. It could be a question on frontal lobe. So you are like, I know each and everything about this. It's a big question. I can score in full marks out of this. I should write everything that I know about it. So this is what your impulse will say, that write everything that you know. But Here is the mistake that most people do. In writing everything, we waste a lot of time. And this does not affect the score in this marks, but it affects the scoring in other sections, the other questions. You fall short of time in the end, and the remaining 5, 10 marks questions are simply inadequate to score 2 or 3 number of marks. And sometimes the worst, that a question is almost skipped because you are not left with any time. So in such questions, the first thing is that you should allot your time as the marks say. Do not overcompensate. It won't give you more marks for the remaining set of questions. Do not overcompensate on this topic, on this question. For example, MHCA is the first question on 15 or 20 marks in paper 3. Do not overcomplicate it. Do not start and write each and every section or explain each and everything. Give the crux. Suppose it's a 20 marks question, 40 points is more than sufficient. 35 to 40 points is sufficient. So just multiply the marks by 2, and those number of points or lines is sufficient. And more smartly, writing 40 points would be a big deal. More smartly, add 1 or 2 tables here or diagrams. So for such questions, simple follow a simple rule. Number of marks into 2. These are the number of points that you need to add, and at least one uh, figure. At least one figure, be it table, be it a diagram, be it a flow chart, anything. So do these things if you get a question like this. For example, if you get a question on serotonin, what is the role of serotonin in psychiatry? Then divide the question into the sections that are required, such as the metabolism of serotonin, how it is produced, about the receptors, about the drugs acting on it, right? About some other conditions like serotonin syndrome, etc. For drugs, just create one table and just explain the receptors, name of drugs, done. So thereby you cover one entire section, you cover these things, and your entire 40 points are covered within this time itself. The next set of questions are the majority of questions. So these form your majority of questions that, okay, I know this somewhat, but I do not remember each and every point. What should I do? And here the biggest mistake that we do is we think and forget the time. So here the time goes in thinking, okay, I need to remember. I remember some of the part. What is the other thing? For in MHC, I remember the sections of admission, but what were the discharge sections? What were the numbers of the emergency treatment sections? So for them, the easy, smart way is to write whatever you know then and there and leave space for what's missing. Do not try to fill it all the time. Okay, I will remember it, I will fill it, and only then I'll move on to the next question. Don't do that. Keep a space. If you remember the admission and discharge section, write that down. If you're forgetting what was there in emergency or you're forgetting advanced directives, skip that. Leave a space, leave half a page blank, and then fill it towards the end. So this is the second type of questions that you need to conquer. And the third is are questions like this that form a rare 20%, but this can be a major part of paper 1 and paper 4. In recent advances or in neurobiology, a lot of times such questions come in where you are like, is this even included in the syllabus? I have never heard of this thing. What is this jargon? The impulse would be to skip it. I don't know anything, no need to write anything about it. But the smart way is to, as the old saying goes, tie a sheep to the tree and explain the sheep. Forget my drawing. So in such questions, whatever is remotely related also to the question, then write about that. For example, I got a question in my MD paper one about thalamocortical oscillatory circuit, something like that. I hadn't read it honestly then. And what could I do? I just explained about thalamus that I had read, or I explained about cortex and some of the connections between thalamus and cortex, and some clinical significance of it, some neuropsychiatric disorders related to it. Supposedly, if you get a question on xanomeline trospium, you don't remember the dosing or the trials related to it, but you do remember that it is an muscarinic agonist. Sorry. So then you just go ahead and explain about anticholinergic system, about muscarinic receptors, about related drugs like clozapine or anticholinergic. Yes, it won't give you a lot of marks, but you can still go from 0 to 1 score. And that in itself will be very helpful here. So those are the three types of questions that you usually face in theory. Now, the second most important thing in theory papers is time management. A lot of students fail to manage time. And as a result, what happens is some of the questions take up a lot of your time and some of the questions take up, you are just writing it down in the last minute while tying your supplementary sheets. So just make a rule. You have 100 marks of paper, questions, and 3 hours, 180 minutes of time. Subtract the 30 minutes you are for XYZ number, for reading the question paper, for tying the sheet, for asking, or for drinking water, for revising XYZ. Leave the 30 minutes aside. You're left with 150 minutes. So approximately for 1 mark, you have 1.5 minutes. So this should be your rule. Number of marks into 1.5 times, not more than this minute. So for the long 20-mark question, 30 minutes is the maximum time that you will write it. No matter how further you go, how much you know, after 30 minutes, just stop writing it and go ahead to the next question. And similarly, for 5 marks question, 7.5 minutes is more than sufficient. To 7 to 8 minutes for a short note question. So divide that very strictly ahead. In the remaining 30 minutes, you will definitely spare at least 15 minutes in the end. And in those 15 minutes, fill these missing gaps that you left in between. Yeah, so the pattern is different. Yeah. Vijit, yes, 10 questions for 10 marks is a pattern at a lot of places. So just remember 15 minutes for each question, not more than that. So, so 15 minutes, you have to complete a question, no matter how much you know about it. That's it. Beyond writing beyond 15 minutes for a 10-mark question, you won't score additional marks in that. So just skip at every 15 minutes. If you think that you can write more, leave a page blank. Leave a page blank. If you're not able to write, just cross it, and there is no issues with that. If you are able to write a few lines there. So that is the second thing that you need to remember in theory papers. Now, before starting to write anything down, whatever question you have, structure the question ahead before writing it down. What happens is that after revising everything, the cramming up in the last 15 days, 1 month of exams, the first question comes in neurobiology that you know very well. And you're like, now I'll write it down. I have learned it. Now I have to show that I know this question. And you start writing and there is no head and there is no end to it. And it looks like you have written a paragraph, 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 and a lot of paragraphs. This to the examiner feels like a boring paragraph. Who is going to read this? And he'll just read a few lines and skip and see the things and whatever. He's also busy coming in between practicals with a limited time. So if there is no structure, you will definitely lose some marks. If there is structure, you are definitely gonna gain marks because of easy readability. So the eye can fix to certain important points within the answer sheet. So for that, when you're preparing, when you're learning, don't remember things just for the sake of remembering. Remember the structure of the answer. Remember the sections of the things. For example, if you are talking about neurosciences, and for neurotransmitters, you have basic metabolism, you have receptors, you have drugs acting on it, right? So these are the basic things that you have to write about it. If you have like say temporal lobe, then you have anatomy related to it. You have some uh, histological changes, so cellular structure, so anatomy, histological changes. Then you have functions of it, and then you have circuits related to it. Then you can write about psychiatric neurological disorders associated with this temporal lobe, and then you can write about role in psychiatric conditions. Sometimes you can also write about neuromodulatory devices that act on frontal lobe or parietal lobe. So this is the standard structure that you can remember in each of the sections of neuroscience. Similarly, for clinical condition, epidemiology, clinical features, differential diagnosis, assessment including scales, then treatment. Then even in treatment, you can talk about drugs, non-pharmacological treatment, right? And then treatment resistance and neuromodulation or ECT, right? You can talk about nosology. So those are the structures that will be there in each of these major questions. So just follow this structure. This helps you remembering, recalling the top points that you need to remember and writing it down and making the examiner feel at ease to read it out. So write in this structure itself. So now, apart from writing in structure, you have to make the answer easy to read for the examiner. He doesn't have time. He's probably bored. He or she is probably bored of reading all these theory papers. She has been doing it for years. He knows what the students will write mostly. He just needs to see that you have written the important points. So first and foremost thing for people, especially like me, who have a terrible handwriting, keep spacing, keep adequate spacing. You have done it already in your MBBS and all. These are just important tips again, back to theory exams. Write in pointers more than paragraphs. So instead of writing this entire how MHCA was formed, falana, etc., etc., write in structure introduction, 2 points, point one, point two, then advanced directives, then further who can make, how it can be revoked, etc. So just structure it out, make points, and wherever possible, make tables and diagrams. So even if you are a terrible artist uh, and only ChatGPT is your only way to make images and artwork, still then make diagrams here, however terrible it is, and label them. This will help you in showing that you know things. So although majority of places diagram won't be possible, so where it is not possible, make a table. If you are given a comparison between geriatric depression, dementia, pseudo dementia, instead of writing that down, make a table, make points against for it. If you're given differential diagnosis, if you have to write differential diagnosis in psychosis, a case is given and you are told that what is the most probable diagnosis, what are the differential diagnosis. Instead of writing the differential diagnosis, make a table. what is points in favor, what is points against it. Makes it very easy. If you are given a thing about treatment resistant OCD, don't write that down. First we'll do this, second we'll make a flow chart, level 1, level 2, level 3, level 4. That's it. Things are over. It makes it easier for you to write, protects your time management. You can skip the grammatical words when you're writing in tables and flowcharts, and it makes it easier to read. And don't overcomplicate things finally. Don't just for the sake of filling pages write each and everything. Examiner does not want to see chunks of text. They want to see whether you know the important points or not. If it's clearly visible, the better. So overfilling the answer sheet will make it difficult to read, and that will make the examiner score less or get bored. So don't overcomplicate. Just write the points that are important, write it clearly, easily visible in pointers, in tables, in diagrams, in flowcharts, whatever manner that you can put forth. So that will help you increase your efficiency and increase the chances of you scoring in the exams. Now, till now, any questions about how to write questions, how to attempt answers in theory? Then we can go ahead with this topic. All right. So now, Mental Health Care Act. Is there anyone in 215 marks and 10 seconds? Yeah. So whatever the number of marks of questions are there, no need to worry. Just multiply it by 1.5. If there's 15 marks, that is approximately 20 to 25 minutes. So just fit in that time duration. If it's a 15 marks, no need to write more than 25 minutes. That's more than sufficient. If it's a 10 mark, 7 marks, no need to write more than 10, 11 minutes, 12 minutes. So that is more than sufficient for you. Doesn't matter the amount of marks. And uh, a rough structure is that have twice the number of points. For 7 marks, at least write 14, 15 points. For 15 marks, at least write 30, 35 points. So thereby there is enough things to score. Enough things to score. If you have written one correct point, at least the examiner will give you half a number. So if you have 30 points, you are close to scoring more. So that will make you efficient also and score. If you increase your points from 30 to 40 in a 15 marks question, you will hardly get 1 or 2 more marks, but it will waste that much time that you can spend in another 7 marks question. If you at the end of the day, at the end of the paper, if you have time, definitely go and add on in that 30 points that you have already written. So number of pages doesn't matter. See, that's what I am telling you. What a lot of time we are in the habit that okay, 30 marks, I need to fill 10 pages. No, you need to have at least 50, 60 points that are clearly visible, that are important, that the examiner can see at one glance. That's it. If it's a 10 marks question, have at least 20 points or less. Also, 18, 20 points is more than sufficient, and the examiner can clearly see that you know the stuff. So that's it. For MCQs, there are question banks on the app. You can attempt those MCQs. It is difficult to fill in the MCQs in this revision lecture, but as we revise this topic, I'll tell you what are the usual MCQs in each topic. Points or paragraph? Pointers, better than paragraph. In paragraph, you are wasting a lot of your time in writing these uh, adjuncts and however, because this, that, and then this happened, so forth. No need to waste time in writing those grammatical. You are not studying, appearing for an English examination. For frontal lobe, if you have, okay, the frontal lobe is located between the central sulcus and above the temporal lobe and extends. Instead of writing that, just write frontal lobe, boundaries, posteriorly, central sulcus. Okay. Further subdivisions, 1, 2, 3, 4. These are the subdivisions. That's it. So that covers the time, looks more cleaner, is easy to recognize for the examiner, and you are protecting your time, efficiently utilizing it. So now let's go ahead into this topic, Mental Health Care Act. It can be a long question. Any of the sections, any of the important features can be a short question, and there can be viva discussion on Mental Health Care Act. It can be part of your long case. So each and everywhere, Mental Health Care Act will come. It can be in an MCQ, what under what section this patient might be admitted, what are the provisions, is direct ECT prohibited or not, anything like that. So Mental Health Care Act will come at any stage in your examination. So now uh, you don't need to remember much of the history for your theory exams or practical exams. No one is too concerned about all the old acts, but we need to know the crux of it. You don't need to remember the Mental Health Act or these other acts, but we need to remember what these were, what their drawbacks were, and why we progressed from there to here. One thing that you should absolutely ratify, mock it up, is that the hallmark is care and rights of persons with mental illness. So this should clearly explain each and everything that is there. Whatever question that comes up in Mental Health Care Act, the first line about introduction should be that Mental Health Care Act is based on the cares, providing proper care, medical mental health care, and protecting the rights of persons with mental illness. And this explains why each and every section is being done and why it has changed so much. So care and rights of persons with mental illness, this is the hallmark thing. Now, the second thing that you should remember and should write in the introductory portion of any question on Mental Health Care Act is the history, that we progress from the Indian Lunatic Asylum Act, Indian Lunacy Act, and the Mental Health Act. And this history is important uh, because here, key features that we need to remember if an MCQ comes up or if it's asked in Viva, what were the drawbacks of these acts, is that the Lunatic Asylum Act was on the basis of asylum, that is prisons, and it was under the government section of prisons only. So the people, the jurisdiction dealing with prisoners also dealt with lunatic asylums. And as we know that there was no progress in treatment, so here there was no medical care. So what the purpose of this was? Protection of society. So they were a threat to the society, hence they should be placed in asylums where they are taken care of by guards and police personnel. So that was the whole idea behind the Lunatic Asylum Act. Now, then we move to the Indian Lunacy Act. So now here the thing shifted from prisoners to not an asylum, but an IPD care, that if there is a person who is a lunatic in those era, he would be placed into a custody. So here we moved from prisoner asylum based care to a custodial care, that they should be put into custody in the IPD. And they, there again, the entire purpose was the protection of society, and there was some medical care here. And then in Mental Health Act, this was the second most recent act, so we need to know a little bit more about it. So here we moved from custodial based principle to a treatment and care based principle. So here it became about medical care based model. And Here, the thing shifted from not just IPD but introduced OPD services and admission under special circumstances, right? And there were special licensing authorities for mental health, uh, as mental health is establishments or mental hospitals was the term then. So this was a mental hospital based, but OPD pro and medical care pro. And there was some talk about guardians for properties and some rights, but the lacunas in mental health act were there was no talk about the rights of persons themselves, right to get back to the community, rights about emergency care and their choices of treatment. And this regulated only psychiatric hospitals. So general hospital were not included in this act. So for mental health uh, care act history, we need to know that lunatic asylum moved from asylums, prison based, custodial care, protection of society based system to Indian Lunacy Act, where there was custodial care, some medical management, but again, the principle was to protect the society from uh, these persons and that they required IPD inpatient stay only. Now it moved with Mental Health Act, it moved to an OPD based care, licensing and authorization and treatment through various OPD services. But there was still no talk about rights, community living, and it regulated only mental hospitals itself, not the general hospital. So those are the things. So there can be a question like what is the difference or drawbacks of Mental Health Act and why Mental Health Care Act was introduced. So this table you can make there. So core approach was medical or care based, and here it's rights based. Patient rights not included here. This is the prominent feature here. Healthcare setting is mental hospitals, psychiatric hospitals only. So it governed only those hospitals. And here we also include general hospital, psychiatry units, any place where persons with mental illness reside. So all types of healthcare setting where PMIs reside is there. Patient autonomy and decision making, no talk about it. Here it is the prominent feature in advanced directive, nominated representative, and decriminalization of suicide was not done. It was still a criminal offense. Here it is decriminalized. Insurance coverage not included, insurance coverage included. There was no talk about prohibited treatments. Here there is talk about prohibited treatments such as direct ACT, sterilization. So these have been included. So those would fill in the primary differences. So rights, approach, autonomy, setting, suicide, insurance coverage, and prohibited treatments. Now, brief things that can come in MCQs. So MHCA was brought in to fulfill the United Nations Convention on Rights of Persons with Disability. So UN Convention on Rights of Persons with Disability. So this formed the basis of Mental Health Care Act as well as the RPWD Act. So both of these were in the international framework of UNCRPD. A few dates that you need to remember is 7th April, World Health Day of 2017. Yeah. So don't worry, we'll share the final PDF if it's legible. We'll share the PDF in the uh, groups also, and it will be uploaded in the app so you can view the lecture again. Oh, this is rarely a question. I haven't read it specifically in the recent years as a question, but just a general information if this comes up. that we moved from a medical-based approach to a rights-based approach here. Autonomy is much more important. Autonomy is shown in the form of advanced directive nominated representative. There is no place of substituted consent in MHCA. There is only supported admission. You can take a screenshot of this. Okay. So a couple of dates that we need to remember. 7th April, World Health Day, 2017, first signed by the president, came into force 1 year, 1 month, and 22 days later. So 1122 days later it came into force. So 2018, April to May, Jan 7th to 29th. So it came into force and it has, so we have been talking about 747, then so 16 chapters and 126 sections. So a lot of double digits, 747, add 11122, and there you have the final date of came into force, and the chapters again 16, just add another 2 here, so 126. Any way that you can remember it. Now, talking about the aims. So this again is a question that is very common. A lot of times I would get asked in Vivas, what are the aims of Mental Health Care Act? And then you have to say it word by word what that is. So this you can remember in shortly that first we talked what is the hallmark. We started from the, yes, that is how it takes time to frame up things in the government regulatory bodies. So usually that actual implementation starts much later. So that is the reason usually you can say with all of the acts, you can say that there is that delay there. And secondly, there was an international pressure to actually approve the law because 10 years was getting completed in 2017. So there was a lot of pressure to complete, implement, get it signed, the law to get it signed within the year 2017, or India might lose a seat in the United Nations WHO. So, because of all that pressure, it was hastily produced and signed, and then implementation takes its own course or due course of time. So those were the reasons primarily. Not of concern in our rapid revision. So we'll get back to revising and remembering things that are important for passing the exams. So MHCA aims, very important. If you do not remember, start with what we discussed in Hallmark. That's it's a care and rights based act. So the first aim is provide mental health care and service to PMI. The second aim is to protect, promote, and fulfill rights of persons with mental illness. And the third aim is to address any matter that those are related to these two things. Simply remember the hallmark: care and rights, aim, provide mental health care and services, protect from and rights, protect, promote, and fulfill the rights, and address any matter that are related to these. So three aims done simply from the hallmark. Now, talking about the 16 chapters. So you don't need to remember each and every chapter by section itself. Just a brief idea in case there is a huge note on MHCA, then you might have to label the name the chapters, but it is not very mandatory. So the first chapter in all acts is preliminary. The second chapter in all act consists of the definitions. So here the major thing is mental illness definition, capacity, uh, and capacity have been defined here. So capacity comes under section 2. Now, once you have capacity, then you can make an advance directive, you can make a nominated representative. So those are the things. Now, this is the most important part here, rights of persons with mental illness. So this section that you need to remember. Yeah, sorry. Definitions have been there in the preliminary itself. So definitions are there in the preliminary. Only thing defining the capacity, what is a capacity is here. So capacity, advance directive, nominated representative, rights of persons with mental illness. This is the most important chapter. This is the core hallmark of it. So in section 5, this is there. Now, the next chapters are not as duties of appropriate government. You won't get a question on specifically these. Then once we are done with the persons, we go on to the government duties, then the central government, the state government, and finance, audit, etc. Again, not important section for us. Then are two important sections on what is a mental health establishment, how to get it registered, what are the sections related to that, and who is overseeing these mental health establishment, that is the mental health review board. Then comes the very important section of admission, treatment, and discharge under section 12. So this is the second most important section that we need to remember. Responsibilities of other agencies, where we talk about role of police, judiciary in this act. Restriction on discharge of functions. The second last is chapter is usually offenses and penalties, and then miscellaneous. You don't need to remember all of the sections by name. Just a brief idea is sufficient. Now, let's go on to chapter 1, the definitions. You need to remember the definitions by heart. So that is there. There is no denying that you have to remember the definition of mental illness. So for that, the wording is a substantial disorder of thinking, memory, perception, orientation, mood that grossly impairs judgment, behavior, capacity to recognize reality, ability to meet the ordinary demands of life. Now, have you all remembered this by today's time, or there is still confusion when we try to recall it? Yes, you need to remember this as it is word by word. Hence, despite revision, I have put it as the verbatim is. So there is, uh, so I'll give one trick that you can do to remember this is that is my pet Tom is just behaving completely abnormal. So my mode or memory, whatever you want to put here, mode, perception. So go in the sequence that we do in MSc, mode, then perception, then thinking, and orientation, and memory. So my pet Tom, how will we call your pet Tom as a person, as a pet with mental illness when he's just behaving completely abnormal? So just is judgment, that impairs judgment. Behaving is behavior only. Complete, capacity to recognize reality, and abnormal is ability to meet ordinary demands of life. So, mental illness is a substantial disorder of my pet Tom. So, mood, perception, thinking, orientation, and memory that grossly impairs just behaving completely abnormal. Judgment, behavior, capacity to recognize reality, and ability to meet the ordinary demands of life. Then there is a plus and there is a minus. So after this, they have defined that it includes abuse of drugs, conditions associated with abuse of drugs, but does not include mental retardation. So my pet Tom is just behaving completely abnormal, plus doing alcohol and drugs, but is not mentally retarded. So this, you can remember the definition. You will be asked in Viva if particularly one of your examiners is fond of definitions, which some of my faculties were. So we had to remember it in each and every thing. Now, the second important definition to remember that can be asked in practicals particularly is mental health establishment. So what is mental health establishment as per MHCA? So this is very important because in Mental Health Act, there was only definition of mental hospitals, psychiatric hospitals that were whole and sole responsible for IPD and treating mental conditions. But in mental health establishment under MHCA, we have moved to any health establishment, including Ayush, but only those where a person is admitted and resides. For what? For care, treatment, convalescence, or rehabilitation. So, uh, and it in and it includes general hospital, even if a person is residing there temporarily. So, even if a person with mental illness is residing for 1 day for treatment at your place, then it comes under mental health establishment and has to be registered. Even if it's an Ayurvedic clinic, even it's a yoga center, even technically a naturopathy center, having person with mental illness staying there would qualify under mental health establishment and needs its registration. Even rehab centers, even halfway homes. So all of this come under Mental Health Act. So for so this is the definition. Any health establishment, including Ayush, where a person is admitted, resides for the purpose of treatment, care, convalescence, or rehabilitation is a mental health establishment. Now, the next definition is that of a mental health professional. And here you can be asked to use a psychiatrist. So, again, any recognized degree and registered with the authority. For clinical psychologist, to be called a mental health professional, you should have a PG in psychology applied clinical and MPhil in clinical, medical, or social psychology. Not very important, not usually asked, just a brief review. Psychiatric social worker, PG degree in social work or MPhil in psychiatric social work. Mental health nurse, diploma or degree in general or psychiatric nursing. Even general nursing would qualify as a mental health nurse here. Or and a PG degree in social work would also qualify as a psychiatric social work. And all of these are mental health professionals. And here we are also talking about people who have Ayush master's degree in mental health related fields, whatever they that is called. So Mansik Arogya. Chikitsa in Ayurveda master's degree would qualify as a mental health professional here. So all of these are mental health professionals. This definition is important when we talk about the admission and treatment sections, because there we need the permission and the assessment from one or two mental health professionals to admit a patient, particularly under supported admission sections. So psychiatrist, Ayush, MDs, clinical psychologist, psychiatric social worker, and mental health nurse, all of these are mental health professionals. Now going on to chapter 2. Chapter 2, section 3 is where it is defined what is mental illness and how will a person qualify for mental illness. There is a gross definition of mental illness that we have talked about, your pet Tom. Uh, that is the gross definition. But how do we determine if the person is mentally ill or not? Then they have explicitly mentioned that it is according to the latest national or international guidelines. So ICD 10, 11 are the framework through which we can determine mental illness. Now, the very important thing is there about the capacity assessment or capacity to make decisions. So this can itself be a question, a short note, and it can be again asked in vivas, in long cases. How will you assess the capacity of this person? So for capacity assessment, learn this mnemonic UAC. There is no other way. UAC. You should be able to understand, appreciate, and communicate. So understand the information. Whatever doctor is giving, patient should be able to understand. Okay, they are telling me this about depression or psychosis. What? Appreciate the reasonably foreseeable consequences. So the usual consequences should be appreciated. So UAC, you can add a C here also, appreciate consequences. So appreciate consequences and communicate the decision by speech, gesture, or expression. Anyway, so not just speech, any form of communication is sufficient. So capacity is determined on the basis of understanding information, appreciating consequences, and communicating by any means. And then under the MHCA rules, the guidance document for capacity assessment was framed. So this is a specific form that is there where the questions are put in. So you can tell that you can uh, assess the capacity using the mental health care rules of 2018, where there is a guidance document on capacity assessment. So there is a form that you can keep in your records for capacity assessment. This is very essential when you're talking about admission in your vivas in long cases. There they may be asked when will you assess the capacity and when how will you assess the capacity? Do we need to keep a documentation? Yes, we need to keep a documentation if the capacity is reduced, if the patient does not have a full capacity. Now, another important thing is here is that all persons are assumed to have capacity at all times until otherwise. So guilty under sorry, innocent until proven guilty. Similarly, having capacity until proven otherwise. So all persons have capacity. If you want to put in a clause of supported admission, then you need to show that the patient had a reduced capacity. So any questions till now? So the shorter, brief introductory portion of MHCA is done. Now we'll go into the longer questions that come in, and this would be a little uh, comprehensive section. So any questions, queries till now? Yeah, just a minute. So section 3, so definition of mental illness has been given and in the preliminary itself, but in section 3 it tells how can one determine if the person has mental illness or not. So they have defined, okay, so and so is mental illness, but how do you assess it, how do you diagnose it? So for that they have mentioned that the latest international and national guidelines are sufficient, so thereby which they means that ICD 1011 whatever version is generally accepted is sufficient for that. You won't be asked a question specifically regarding it. In the long and short cases book, is it given in the same format? What is long and short cases? I am not clear about your question. Yeah, are you talking about the Q&A book? So Q&A book, we have the bigger questions, the advanced directive, nominated representative, criticisms, etc., given in a very similar format. And rest of the things that I am telling, such as the mnemonics and all, those are not there that I have made specially for this class. So those are mentioned here. And these are not, so the Q&A book is primarily about the theory based exams. So I am also trying to cover what can be asked in practical vivas and things because it is a wide topic. So those parts are not as it is. Now, the major questions that will come, such as advanced directive, nominated representative, admission, discharge. So those are very similar to the Q&A bank, almost were uh, exactly the same, except for some parts, so that you can directly correlate there. You can open the book and read it along, so that can be helpful. So now coming to advanced directives. So this in itself can be a 5 marks or a 10 marks question. So this is something that we need to learn in a very structured. Yes, as I mentioned, the majority of questions that we are discussing about theory exams are similar to the Q&A book, but some of the practically important things like definitions, what to tell, how to assess capacity, so those things are not given word to word. So Q&A book you can refer to after the lecture, but for the time being, it's better you just be present here. If you want to note down a few things, you can note down. After the lecture, the PDF, annotated PDF will be provided and it will be uploaded. So now let's hurry up. We don't want to go very late into the night now. So advanced directives. So this can be itself a big question. So advanced directive, if there is a question on advanced directive, firstly, you introduce what MHCA is, under what chapter we talk about advanced directives, and why it is important. Then you define what an advanced directive is. So this is the definition. The definition includes that it is a document that guides, uh, that is guiding and telling about whether a person wishes to receive mental health care or treatment, and it is also a document that decides the appointment of an NR. So a document made by any person which guides a mental health professional about their liking or preference for receiving mental health care treatment or its type or any modifications, and the also about the appointment of their nominated representative in cases where they lose their capacity. So that is the definition. This has been mentioned in chapter 3, and section 5 tells that any person when in capacity can make an advance directive, and for a minor the legal guardian is the uh, legal guardian can make an advance directive for the minor. Now, the second important section in advanced directive answer is documentation and registration. So, for documentation, just writing on a piece of paper is not sufficient. You need to have the signature of the person. If a nominated representative is there, then their signature, and get it registered at the mental health review board. So they keep the registration and tracking of all the advanced directives. And uh, so that is the process of documentation and registration. So the second uh, section would be about documentation and registration. The third section would be about operationality and revocation. So how does an advanced directive come into operation? So it comes into operation when the person loses capacity and remains in operation till the person gains capacity. So it is only operational in between the time the person does not have a capacity to make healthcare related decision. So during this time, a person's advanced directive will be implemented. So to implement that, the person himself or the nominated representative is responsible to give this advanced directive to the mental health professional. So in operationality comes into being after losing capacity, goes is not applicable once the person gains capacity, and the person themselves or the nominated representative is responsible for giving it to the mental health professional. And under section 10, it is the duty of mental health professional to follow an advance directive, meaning that if you are given an advance directive and the person is not in capacity and it is operational, you have to follow the advance directive. Yes, yes. So yes, until and unless there is a new advanced directive, the same advanced directive will be applicable. But it has to be registered with the mental health review board. So without registration, it is not applicable. Now the third thing is, what are our obligations? Now we have talked about what is the operationality, what are our obligations as professionals. So we have to follow the advanced directive once it's given, it's registered, and there is protection also that if something goes wrong and advanced directive has said to do so, and if there is any unforeseen consequences, then we are not responsible. But here the important thing is it's an unforeseeable consequences. Supposedly, if the patient says that patient is a case of bipolar disorder, and in advanced directive he has said that if I lose capacity, I want to be treated with an antidepressant as citalopram. Now you know that it has a clearly foreseeable consequences of risk of mania. Uh, if there is a foreseeable consequence, then you are not safeguarded by the law. You have to report that it is not of the best interest, and then you can put a complaint to the MHRB and the advance directive can be revoked. But if there is any unforeseeable consequences, uh, such as Steven Johnson syndrome or any idiosyncratic reaction occurring to a drug, then it is not uh, you are not liable for it. That is the rights and the opinion by the patient. Now, limitation is that where it is not applicable in emergency, and if there is any illegal clause. So supposedly if the patient in India says that I want to be treated with cannabis supplements for my depression, so then it is clearly against the NDPS Act. So this is not applicable. So these are the limitations. Now, what are the review mechanism? So in case an advance directive is wrong, for example, if the patient has said that I want to be treated with antidepressant uh, escitalopram during my bipolar depression phase, and you know there is a risk of switch, then you can give an application to the MHRB, and even a caregiver or relative can give, and the MHRB reviews or cancels the advance directive if it was under forced will, if the circumstances were different when the person was trying to make an advance directive, he was not well informed about the consequences, and was made when the patient was not in capacity. So under these conditions, the advance directive gets cancelled. So in a question of advance directive, we start with MHCA basic introduction. We talk about the definition of advance directive, who can make it, adult in cases of minors, how it is documented, how it is registered, when it comes into operation, when the patient loses capacity, gains capacity, what are the obligations of the mental health professionals to follow it, and the safeguard is that we are protected against unforeseeable consequences. Then what are the limitations when it is not applicable, when it is illegal, or in under emergency cases, and when can it be reviewed, when can it be modified. So those are the sections under which you can explain a question on advanced directive. So this will complete approximately 15-20 points about this topic. Now, similarly, the next question is on uh, nominated representative. Again, a short note, possibly even a long question can come on it. So again, when we start any such question, the question starts with talking about MHCA. The hallmark was how we moved from in custodial care, substituted consent to a supported consent, supported per kind of a structure. So this is the core idea behind uh, the nominated representative. That in Mental Health Act, we were talking about guardians, that there are guardians of the property. What's the term? If the person is mentally sick, then there is a guardian who can handle the property. But here we are moving to the autonomy of the person, that they are autonomous until and unless they lose their capacity. And even if they lose their capacity, they still are not completely under the whole and soul wishes of the guardian. So nominated representative, hallmark, MHCA, we talk about guardian based to autonomous decision making. Second thing, we talk about what is a nominated representative and how it is appointed. Then we go on to what are the sections of appointment and revocation of nominated representative. So this is an important section. Section 14, appointment and nomination, nominated representative. So you can remember it as 14 already containing NR. So for NR, you can remember 14, whatever works for you. So again, we need to talk that any person can appoint it. Nomination is to be made on a plain paper in writing with signature and again registered with MHRB. So this is just similar to advanced directive. The NR should be adult, competent, and consenting. So you can't just nominate some person and not have their consent as an NR. So you should have their consent in this. There is no mention that it has to be a relative, it has to be a spouse, it has to be the children, XYZ. You can appoint any person as an NR till he is adult, competent, and consenting. For minors, the standard legal guardian is the NR. For minor, there is no option of uh, giving it to anybody else. So this is the section about definition and who can be appointed. And what is the option if there is no NR? If there is no NR, then the MHRB decides. So the Mental Health Review Board is the deciding person. They can give the nominated representative to these persons in order of their preference: a relative, caregiver, person appointed by the board, or Director of Department of Social Welfare or their representative. So by the board and Director of Social Welfare. So RCP to remember for the preference of nominated representative, relative, caregiver, board, appointed person, or the Director of Social Welfare. Now, what are the rights and duties of NR? This in itself can be a short question separately, and it can be under this nominated representative. So to remember this, remember that nominated representative is a proxy of the person when he was in capacity. Supposedly, I lose capacity and someone is NR, then he should think like how I would be thinking when I was in capacity. So he should consider the person's wishes, life, values, cultures, best interests, their views of the person, usko, that should be placed as very important. And their role is here what we make mistake is that they will take the consent, they will give the consent for any procedure. No, their entire role is to provide support in making treatment decisions. So even in high support needs, until and unless there is 100% loss of capacity, the person itself, himself or herself will take the decision. The NR will support them in taking the treatment decision. And uh, only that they can, only option here is that they can give consent temporarily if the person has no capacity at all. If the person loses complete capacity, then they can give a consent only on a temporary basis. And as soon as they gain some capacity also, then they only support them in taking treatment decision. So views of the person, treatment decision support, proxy decision in case of complete loss of capacity only temporarily, admission, discharge, and research. So give consent for research also can be done here. And in cases of children, appointing a suitable attendant, or if the person is not there, then appointing an attendant is also one of the duties. Apart from it, they can again, the rights that have been given to persons with mental illness, they again fall into this nominated representative's hands. They can seek the information about treatment, get access to rehab cares, and apply to board about violation of rights. So complain. So all these three are again just the rights of persons with mental illness that we'll talk about in the next section. So rights, admission, discharge, personal views, decision making, and research. So you can crossly divide it into five things: admission, discharge, research, rights, and personal views and decision making. Now, when can you remove an NR? You can remove an NR. The person themselves can remove it at any time. The Mental Health Review Board can remove the NR if an application is sent by psychiatrist, mental health professional, or any relative or person with mental illness. Or if the NR is unfit, unwilling, or not acting in best interest, then you can send an application and the Mental Health Review Board can revoke the appointment of an NR. Now, the next important section here is clinical significance. Under what section are they important? In supported admission, section 8990, decision making support, giving temporary consent, and in emergency treatment also they can give consent on temporary basis. So in emergency treatment section, we'll talk that if a nominated representative is there, then their consent can be taken. How is this different from previous structure? Is that we are talking about supported decision making, not substituted, which was under Mental Health Act. And own choice representation, and this is also overseen by mental health review board. Now, how to apply the practical uh, ways to see for an NR? If a person comes to you and says that I am their NR, then you have to verify with the document, see if they are suitable or not. If not, you can complain. Keep a record of who the NR was for this person. If there is a dispute, resolve it between NR and family members if there is anything like that. And develop protocols if there are multiple potential NR. So if there is no NR appointed and you have to choose between various relatives, what is the protocol? So that has to be developed. So those are the practical implementation. So for NR, we have to talk about how MHCA is structured, how it has gone from guardian based to autonomous based. We have to talk about the definition, who can appoint, when can it be appointed. We can talk about adults and minors. Then we have to talk about if there is no NR, then who is appointed, what are their duties and rights, admission, discharge, treatment, uh, uh, decision making, supported and temporary, and rights, complaints, when can the NR be removed, where their roles comes in, how is it different from before, and how to verify the NR, what documents to keep when checking for nominated representative. Any questions, any queries till now? Is the pace all right? Is it too slow, too fast? I know this is a boring topic, but thumbs up or yes, no would be great. All right. So now moving on to the next topic, rights. No, there cannot be more than one NR. If a person has appointed an NR in an advance directive, there is only one NR. But if the person has no NR and he has lost capacity, now then it is up to the mental health review board to appoint an NR, and the psychiatrist has to give an application who I would like to appoint an NR. Then out of that n number of family members, caregivers that are there in Indian household, who would you appoint? The father, the mother, the son, daughter, wife, who would you appoint? So choosing between them requires a structured approach. You should document that why you chose someone. So that is the thing. Not under MHCA, just a practical point for it. So now talking about one of the most important sections, rights of persons with mental illness. This can come in a separate question itself. So when if you have to write a question about the rights of persons with mental illness, again start with MHCA, why it was done, what is the hallmark, rights is the basic feature of it, and then why there was a need for rights of persons with mental illness. So there you will we will talk about that persons with mental illness because of the proxy decision making, the guardianship model, the custodial model, there was a lot of discrimination, lashing, beating, physical torture, stigma that they can't make any decision, they should not be married, they should not do job, they should not roam free. And there was denial of in basic human rights. Give them the worst possible quarter, give them the worst possible thing. Why do they need new clothes? Give them the uniform of the jail. So those were the scenarios. So to protect them from that, the evolution came from Indian Lunacy Act and those acts. And then the UNCRPD talked about equal rights of each and every person. Hence, we came with the rights of persons with mental illness. There are 11 rights from section 18 to 28, but remember it as uh, that it is only 10 because one of the rights is just a double representation. So you can remember that section 5 talks about rights. There are they are 10 and right and 8 rhyme. So 18 to 28. Right, right, 8, 5, 10. So section 5, 10 rights from 18 to 28 is the thing. Now, so talking about, we'll go into one rights and what they represent and then make a way to remember it. So one thing, first, remember it as a story. If you are a person with mental illness, what would you do? First, you will go to the hospital. So the first right is right to access to mental health care. And by access, what does the Mental Health Care Act mean? Is that it should be cost affordable, it should be quality, it should be accessible, not very far, not the entire state having only one mental hospital, not that. Accessible becoming in each district, so least travel. And provision of not just IPD care, which was there in MHA, but acute care, emergency care, halfway homes, family care, rehab care, care that supports community living. So, not just getting admitted, but also going back to the community. Free care for persons below poverty line should be available. And minimum quality standards. Free care also includes free essential medicines and minimal quality standards and budgetary provisions to provide the same. So, in right to access, there is talk about cost, accessibility, minimum quality, range of services, community living, free for poor patients, and free essential medicines, and budgetary provisions. The next, once you have gone to access, you have accessed mental health care, you want that I want to come, but I also want to go back. So the next is community living. I don't want to stay in a mental hospital forever. Want to get admitted and get back to my home. So right to community living. So that also includes appropriate support from professionals to get the patient back to the community, as well as legal rights for family home. So that becomes essential. So 2 points in community living, us supporting, and also legal right the person have to get back to their family home. If the family wants to put them into asylum, let them be there, and the person wants to go back to the family, they have a legal right to file a case to get back to the home. If you have come in, you know that you have the right to get back, then what you want that till the time I am here, I don't want any cruel, inhuman treatment, any discrimination. So protection from cruel, inhuman, degrading treatment, which means that there is no role of uniform, tonsuring, forced labor work, unhygienic conditions, stay good food should be there, good accommodation should be there. So no inhuman, cruel treatment, no seclusion, solitary confinement. So these should not be there. So that is the second thing. Okay, so you're done that. Okay, my APD stay is not cruel, inhuman. Now the next thing I want is that you should treat me equally, equal to a person with physical illness. So equality and non-discrimination. No discrimination that I am a patient with mental illness means that if I get a cough, I should get the same quality of treatment as any other person with cough. So no discrimination in terms of when compared to persons with physical illness. That also means that medical insurance should cover mental illness. And that also means that if I am a mother with a child less than 3 years, she should not be separated just because she has a mental illness. So the right to equality and not discrimination has a range of things: equal treatment as physical persons, coverage of medical insurance, and not separating mothers. Now, if I am admitted, I am sure of this, then I want, what is the information? What am I getting treated for? What is my treatment? So, right to information about the condition. If I get the information, I should also be sure that my information doesn't leak out. So, right to confidentiality regarding their treatment. My treatment of schizophrenia should not go into public, should not be said to any relative until I tell them, should not be told out to my authorities, job seniors. And here there are important exceptions that we need to remember to right to confidentiality, is that nominated representative and mental health professionals have right. This does not apply. It's getting back just a minute. And if there is a risk of harm to another person or risk of violence, then that information is to be shared. If the information prevents threat to life, so if the person is actively suicidal and that information has to be shared, so you have to share that. If there is an order by the board, state mental health authority, or court, then you have to share. If there is risk of public safety or security, then it has to be shared. So, right to confidentiality, except for nominated representative, no mental health professional, harm to other person, harm to self, threat to life, government order, and public safety. Uh, Now, similar to this, the 24th is the similar right to confidentiality, but in terms of release of information in public. So release of information, particularly photographs, should not be released in press or media. So this is mainly for media. It is not essentially a sole independent right. It is just an extension of this, but specifically for media and photography related purpose. Now, if I have the right to information, right to confidentiality, I also have the right to access my medical records. Give me my discharge summary, give me my IPD records if I request. And only another, again, here the exception is that if the information uh, has a potential of causing harm to any person, then you can withhold. Once I get the records, I also have the right to personal contacts and communication. So this means that I can communicate a person, a family member by phone or email. Then if no one is listening to me, I have right to legal aid. And here there is a mention of free legal aid. And if still no one is listening, there is cruel treatment, I can complain. I can complain up to the mental health professional, if not the in charge of the establishment, if not the mental health review board, if not then state mental health authority. So these are the rights. So a simple way to remember is that you should remember how one goes from a hospital to discharge. Walk into the clinic, meaning access to care. Look back, so can you go back to the community? Now you enter the ward, so protect from cruel treatment. And then you meet the doctor and tell that I want treatment just like any person, so equality. You can ask question, get information, and you can tell them to keep it a secret, confidential. You can check the basic medical records, getting your records, and you can call, communicate any person. You can call for legal help, and if nothing, you can complain. Soumya, is this the slide? So once again, remember You are a person with mental illness, you want to go to a mental hospital, you will talk about, is there a mental hospital? I want access to it. Is there is a mental hospital? Won't I be locked in forever? I want to go back home, right, to community living. Okay, I am coming in. I want to stay. I'm getting admitted. I want humane treatment. So, right against cruel, inhuman treatment. Okay, I stay here, but I'm not getting treatment for my physical condition. I have a sore. I want treatment. So, right to equality, non-discrimination, insurance, staying with your children, etc. Okay, I get that, but I need to know why am I admitted? What is the illness? Right to information. Okay, but don't tell my secrets to my family members. Right to confidentiality. Okay, you haven't told that, but now I need my records. What was I treated? How long did I stay? Access to records. Yeah. But you're not allowing me. I need a lawyer to get back to home to compete. And no one is listening to me. I have the right to complain. So that is a very simple way where you can remember. Is it done? Soumya, is that okay? Now, another way, if you can't remember the story and you prefer mnemonics, then remember that access is all. Community cats can eat ice cream, rats chew lemon candy. So if story is not your thing, then remember these rights in this way. All cats can eat ice cream, rats chew lemon candy. Doesn't make any sense, but it's a fun way to remember. So access, community living, cruel treatment, equality, information, confidentiality, records, contacts, legal aid, and complaints. All cats can eat ice cream, rats chew lemon candy. So thereby there should not be any problem in either ways. You can remember all the rights. Okay, should we move on? So now when we are writing a note on rights of persons with mental illness, if it's a short note, then just explaining these rights would suffice. But if it's a longer note, we need to also talk about some of the other things associated with these rights. So we made a brief history, how these rights came into being, etc., why it was needed. Now we also need to talk about the legal frameworks, how these rights are protected. Now, apart from this act, the RPWD Act also gives rights of persons with mental illness, persons with disabilities, because all mental illness can be taken as a person with disability, and they get additional rights and additional protections under RPWD Act. So MHCA is not the whole and sole place where rights of PMI are discussed. In RPWD, it is also there. So here, the specific rights that are there is that there is uh, so understand that Mental Health Care Act is dealing with rights of a persons related to mental health care treatment. So hospital, when a person is going to the hospital, then only we are talking about MHCA related rights. So there is some complaint, there is some access, I am not able to call, I am forced to shave my beard, etc., etc. So that is the rights of a person with mental illness in the mental health establishment. But outside, in the public place, if a person is discriminating, if a person is hitting, abusing, making fun of, then RPWD protects them. So there are specific offenses against discrimination of persons with disability. And as we know, majority of mental illness can get a uh, disability benefit. So there are rights and penalties discrimination in terms of discrimination in public under RPWD Act. And apart from it, the Constitution also gives the right to, Article 14 gives equality before law, Article 15 about non-discrimination, and Article 21 about life with dignity. Now, to make your answer more comprehensive, you need to also talk about the challenges. Okay, there are so and so good story and everything written in the law, but what is the reality? What is the challenge in particular? Is that stigma and discrimination in so much that sometimes we as psychiatrists also make fun of these things, knowingly, unknowingly. So stigma and discrimination is absolutely there. There is no denying it. Each and every person is still has that. Then you are talking about resources that we need to build in every district, get free treatment, get free medicines. Where are the resources? Where are the mental health professionals to do that? Then, even if you do all of that, the person themselves with mental illness is not aware that they have a right to communication. Even today, in rehab centers that I visit, a person is not allowed to talk until and unless the doctor allows them to talk on the phone. Majority of places confiscate the phones of persons residing there. So the person themselves is not aware of their rights, that if I have capacity, I can get discharged the next day. 24 hours is the maximum. So until and unless the person is aware, what is the purpose of writing it in law, legal paper? And then who is monitoring if the rights are being followed or not? So for that, you can talk about implementation. So for implementation, you can write a few points that we need to reduce stigma by awareness campaigns, make people aware about their rights. No, both. Wherever it is possible, both. The first thing that you will write about is MHCA. RPWD has only a couple of things. So again, we are talking about civil rights only. The civil versus criminal rights wala thing would come when we're talking about the McNaughton and testamentary capacity and all of those things. Then the criminal procedural part will come in. For civil, all of this is civil law only. So again, for implementation, we need to allocate budget, need to do training of professionals, and mental health review board needs to be made strong to monitor the implementation. So that is it about rights. So it's very simple. Remember the story or the acronym, and rest you can just replicate from basic GK and write about the history and some challenges and other related rights. Now, uh, another question that sometimes comes in terms of MHCA is the duties of appropriate government. So roles of government, but it is usually a very short question or like an MCQ or anything. So need not remember it in much detail. Uh, So here we need to know that in chapter 6, there is duties of appropriate government. They just talk about making the programs, creating awareness, budget allocation, and developing the human resource. That's it. Now, the next two important things, the Central Mental Health Authority and the State Mental Health Authority. These two are very short topics. They can come together as a combination or when there is a long note on Mental Health Care Act itself. Then you need to talk about them. Otherwise, they are not essentially very important, directly relating to us. So in both of these, you need to know what their composition is, what their roles are. That's it. That is sufficient. Just two things that we need to know: composition and their functions or roles. So compositions, Central Mental Health Authority, we have the Secretary or Joint Secretary of Health Department, Director General of Health Services, Director of Central Institutes of Mental Health, any mental health professional with 15 years of experience, one from each of the other professionals, psychiatric, social work, clinical psychologist, mental health nurse, the four types that we discussed, two members, either person themselves or the caregivers of mental illness, and representatives of NGOs. So that gives us one. This number is not defined. 1, 3, 2. This is again not defined, but at least 2. So, so approximately 10, 12 people this consists of. Secret. You don't need to remember it. No one is going to ask that. Just a brief idea that the representation. Now, why this is important? Understand the crux. Here, the Central Mental Health Authority is not made by the administrative persons primarily. It is made by the persons with mental illness themselves. So they have a representation in the authority. The NGOs have a representation. All the mental health professionals have a representation, psychiatric nurse, clinical psychologist, everyone. The director of a central institute has a representation, and then general health services and health department administration is also there. So they have their representation. Now, for at the central level, what is the role? They register all the mental health establishments under central government. So all your INIs and wherever CIP or demands, everything that would come under the central government, they keep a registry and a national registry of all mental health professionals. They will make the provision of norms and supervise the complaints against the deficiencies. And they will train the police, mental health personals, and advise the central government. So, registration, norms, and its applicability, and training people, advising government. That's it. Similarly, state mental health authority. So, uh, I believe a slide is missing here. Let me get back. So, similarly, state mental health authority would here be responsible for registration at the state level. At state level, this means that we are talking about all the mental health establishments that are present in the state. And registry of all the personals in the state. Similarly, making the norms, receiving complaints. So similar to Central Mental Health uh, Authority, and again training mental health professionals and any other function that has been mentioned. So those are the functions of the state mental health authority. So just give me a minute. Should we take a 5 minutes break or should I continue? All right. So the composition of state mental health authority is missing. You can refer to the books or towards the end, I'll get back to it. Not very important. Chapter 9 is about finance, accounts, and audits. Absolutely not important here. Now we'll talk about another important thing, mental health establishments. So this is important from the point of view of practicals, and a general short question. So mental health establishment has been defined that any person with mental illness who resides during the period of treatment, convalescence, care, or rehabilitation, uh, at any place, any general hospital establishment is a mental health establishment, and that needs to be registered. So the registration is done under Section 65, and the minimum standards for mental health establishment and mental health professionals are defined by the SMHA and the CMHA that we discussed. The minimum standards of quality have been defined by them. The procedure is that first a 20,000 rupees payment is made to their name, and they give a provisional registration. This provisional registration is given within 10 days and it is valid for 1 year. So as soon as if you have a mental health establishment, you apply the form, fill the form, give 20,000 rupees DD, check whatever, and you get a provisional registration in the next 10 days. Until 1 year, that is valid. And after which, if the establishment meets the requirements, then you get a permanent registration. And a permanent registration needs to be applied within 6 months of notification. So once the minimum standards have been notified, you have to apply for permanent registration within 6 months. And once permanent registration is done, it's done for 3 years. Now, if the minimum requirements are not met, the SMHA will send an objection report. Okay, these are the objection. Then you can send them that, okay, we have complied, a compliance check is done, and then they can approve within the next 45 days, 1.5 months. If not, if you're not able to comply and they do not approve this compliance report, then you can again submit an application in the next 6 months that we have rectified all the missing things. And this license again has to be renewed at least 1 month before expiry, and the penalty can range from 5,000 to 5 lakh rupees. And then regular audits are done at every 3 years to renew this permanent registration, or if there is any complaint. Simply mental health establishment, if there is a question, define what it is under the thing. MHCA, why it was done? Because to safeguard the provisions, ensure quality of care, minimum standards of care. Who gives these provisions? SMHA or CMHA gives the provisions. How to register? Provisional certificate, provisional registration you can do by sending a demand draft or check in this amount, and it is given within 10 days, valid for 1 year. Then you apply for permanent registration. If requirements are met, you get a permanent registration applicable for 3 years. Renew every 3 years, at least a month before expiry. If there is an objection, you can send a compliance report within 45 days. If still not fulfilling, then you have to resubmit in 6 months. Simply that. Now, this is again a very important question. Again, can be a full 10 marks question. So need to know this as very important topic here. So mental health review board, if there is a question, again start with basics of Mental Health Care Act and why it is there. So we have talked about Central Mental Health Authority, State Mental Health Authority. This structure is very similar to Mental Health Act of previous, who will give license to mental hospitals, etc. But now Mental Health Review Board is in is the protector of this rights and care of persons with health. So we talked about that Mental Health Care Act is all about care and rights. But who is going to ensure that these rights are getting fulfilled? The healthcare is given properly, the restrictive treatment is not given. So MHRB is responsible for that. So this is the protector of the rights. So this is the protector, this is the crux of the roles of MHRB. So wherever we talk about rights, wherever we talk about healthcare, admission, discharge, the supervising body is not the SMHA, it is the MHRB. When we talk about quality, provisions, registrations, the general administrative work, that SMHA, CMHA will. But wherever there is treatment and rights, MHRB is the person, is the body to go. So MHRB by MHCA should be there in Just a second, the device has been disconnected. Joining again. Yes, so we are back. We were discussing about mental health review board. So the basic framework is that they are the protectors of the rights and care. So this is the supervising body that is responsible whether you are giving the appropriate care and taking treatment properly or not. So that is the role of MHRB, and it has to be present in Hima. You want to say something? Why can't? That is the entire purpose. So this is the exact thing that MHCA is about. Why are we assuming that a PMI cannot take decisions? Is not an intellectual person. So this is the type of discrimination that MHCA wants to remove. Can't a person with depression have the capacity to take decisions? Can't doesn't don't they have a say? If the person with bipolar disorder is in remission, why can't they talk about their illness, their experience to a board? Why can't a person with schizophrenia in remission talk about their experience? So that is the entire purpose. They have to have the representation in related question. Yes, that is the genuine arson. If a person had a psychotic episode of schizophrenia and is treated and is on medication and is functioning well and is doing everything, why do you want to remove him from an administrative role? So that again is because we assume that all mental illness are severe mental illness that cannot be treated and every schizophrenia is close up in resistant schizophrenia. No, 80 to 90% people are able to function with appropriately with appropriate treatment if given at the right time. So why are we denying them the rights? So it's not an umbrella term, PMI. Yeah. So the MHRB is consists of the district judge. This we need to remember. The district judge, representative of collector or district magistrate, one psychiatrist, one registered mental health practitioner, two persons with mental illness or caregiver or their organization or a representative from the NGO. And each MHRB is appointed for a period of only 5 years. So it's not like that the MHRB will remain forever. And their retirement age is 70 years. So they can be there till 70 years of age. Now, functions, whatever that we are talking about in the next section, are all functions of MHRB. They have a role there. Each and every section MHRB has a role. So start from the starting, everywhere MHRB is role. Advanced directive, they are registering it. They are seeing if it is legal or not. They are seeing if there is any complaint against it or not, if it needs revocation or not. Again, nominated representatives, they are registering it. They are receiving their complaints. If it needs to be appointed, if there is no nominated representative, then they can appoint, MHRB can appoint a relative caregiver, XYZ, the sequence RCB, the director of social service or social welfare. So they can represent that. So advanced directive, nominated representative. Admission and treatments, we'll discuss that. For all supported admission, it needs to be reported 89, 90. For minor admissions, it needs to be reported. For psychosurgery, permission needs to be taken from MHRB, right? So all of these treatments are there. For emergency treatment, sorry, for not for emergency treatment, but for restraint, a report has to be sent to MHRB. Then grievance, all complaints. If a PMI complains against a mental health professionals, if there is deficiency in care, and they can also take suo moto cognizance. Thereby, if no one complains and if they find there is a problem, then they can themselves take suo moto cognizance. And lastly, inspection, mental health establishment as well as prisons. So this is something that we forget, that not just hospitals, but prisons also they inspect whether if there is any prisoner with mental illness present there. Now, what are the rules? So functions we have talked about. Yeah, ECT will come back. So MHRB has a role in giving permission for minor patients receiving ECTs. So for minor patients receiving ECT for psychosurgery, you need a permission from Mental Health Review Board. And you need to report on restraint use, minor admission, supported admission, all that needs to be reported to Mental Health Review Board. Now, rules, each MHRB has to meet every 3 months. Any complaint that you send there has to be acknowledged within 24 hours and reported in 90 days. They are meeting at 3 months, so 90 days would be the obvious answer. So you get 90 days. Within 90 days, they have to respond. And if there is an appeal, then they can you can go to the state mental health authority or high court. Now, the purpose, the vision is that before there was only a single board, single authority managing from the center or the state headquarter all the mental health hospitals. So that was not possible. Now we have established the authority within the district itself at the local level. So this is the decentralization of oversight. So, and this gives the MHRB legal powers. They give them clinical powers to decide whether this patient needs admission or not. And it gives them community powers to talk about community treatment and uh, representation from the community within the MHRB. So decentralization, legal, clinical, and community powers. So MHRB, you need to talk a lot. The points are concisely written. The answer would be very long because each of these functions, you need to explain multiple points where MHRB's role comes in. Now, the most important section, a section that we need to remember word by word, letter number by number, because it is going to be asked. There is no escaping this. Admission, treatment, and discharge. So now we'll go one by one through each section, what it says, try to remember that, and then summarize it towards the end, what each section contains. So this is chapter 12, admission, treatment, and discharge. So the basic Again, framework is that we have moved from a custodial to autonomous decision making in terms of this ATD. Now, the first, this starts from 85, but we need to remember things from 86. 85 just explains what is an independent patient or admission. So, so any person who has capacity or requires minimal support is an independent patient. Now, 86 talks about independent admission of major. Now, in this, there are specific requirements. So before it was like if you have mental illness, go to IPD, set up lunatic asylum, whatever, and stay there forever. Now we are talking about go there only if there is a severe illness, if you're likely to benefit from admission, if you understand why you are getting admitted, and if you're freely willing to get admitted. So thereby the autonomy comes in. Severe illness, likely to benefit, willing to go, and understands the reason behind it. Then only a major person is to be admitted. So not like every person you can admit if they are requesting. The patient requests, I have severe panic disorder, keep me here forever and whatever I need constant treatment. If there is severe, if they are likely to benefit, if they understand, then only you can admit under MHCA 86. Now, once 86 is done, we are talking about independent admission of minor. So when we talk about independent admission of minor, we need to talk about how to do it. So operationality or criteria. So when it is applicable or application, so this application is to be submitted by nominated representative. So we have already discussed that nominated representative in a minor is the legal guardian. So the guardian or parent itself will submit it to the in charge medical officer. Then application, the second point is authorization, needs to be done by two psychiatrists or one psychiatrist plus a mental health professional or a registered medical professional. So any doctor or a mental health professional plus a psychiatrist needs to be. 85 is just defining what is an independent admission. 86 is the section for independent admission of adult. 87 independent admission of minor. 85 is like the definition of independent admission. So that will not be invoked when you admit the patient. 86 will be the number that you need to remember. Is it clear? So authorization here for adult, there is no authorization needed. You feel that he needs to be admitted, this criteria are fulfilled, admit him. For a minor, you need permission from not just you, one another person, either medical RMP, another mental health professional, or another psychiatrist on the day of admission or in the last 7 days. So any person, any medico, remember it as any medico. So one psychiatrist plus one medico or psychologist. So that covers everything. And not just that, despite that, you need to fulfill a criteria that again, severity is sufficient, likely to benefit, same as adult, community alternatives have failed or unsuitable, and is in best interest of minor. So these are the criteria for a minor admission. Apart from it, what are the requirements if you need to admit the patient, a minor there? They should be accommodated separately, not with adults. A guardian has to stay, and this has to be female for a female. So no male guardian can stay with a female child. This is very important. And it has to be informed to the mental health review board in 72 hours. And review has to be done by the MHRB in 7 days. So the MHRB has to review whether this is a justifiable admission or not. And if the admission is more than 30 days, then again you have to inform the MHRB. So in 87, not just we are talking about application, we are talking about authorization, criteria, application, authorization, criteria, and conditions of ward. Now, both have been admitted, independent adult, independent minor, then you need to discharge them, independent patients, irrespective of adult or minor. So the patient can request without MO consent. So the patient to request discharge does not require the permission of the doctor. So even if the doctor is unwilling, the patient can request, and then he has to be discharged within 24 hours. If no female relative with female minor, then get a female guardian. The nominated representative can appoint a female attendant to stay with the female child. So any caretaker, sometimes there are professional services, nurse, etc., who can be professionally hired to stay with the patient. So if the NR feels that they are adequate, then they can appoint that person. Now, independent admission, the patient can request has to be discharged within 24 hours. If you're not discharging it and you see that no, they requires, then you have to convert it into Section 89 of supported admission. And for that, you need to again inform the mental health review board. And if the nominated representative denies that I don't want to apply under supported admission, then you have to discharge it. So you can't just keep the patient forcefully there. You have to say that the patient's capacity is lost. I need to admit him under supported admission. Then you need to seek the permission of NR, because NR is the person who actually applies for supported admission. So if he denies, then it's done. You have to discharge him or her. Now this the most important section, the supported admission or admission of a person with high support needs. So many a times what happens is that we make the mistake of calling this as involuntary admission. This is not the term, do not use it. This was in Mental Health Act, and we used to call this as voluntary admission. So again, this is not the term. Do not name it. It is independent admission, and don't say that dependent admission. Say it's supported admission, admission of patient with high support needs. Again, this can be done only on NR's request. And for this, again, you need one psychiatrist plus a mental health professional or medical uh, a personal examined. So similar to a child in the 7 days. So similar to child, you need the similar examination. So again, we have application by NR. What's the other? AACC. Authorization. We need authorization from psychiatrist and MO. Then we need to fulfill the criteria. And this criteria is very, 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 very important to know. When is a person fit for supported admission? So the actual wording is much more longer, but you can just remember it as harm to self, harm to others, or inability to take care of themselves. I have remembered it as HSN, which is harm, self harm, or neglect. So the actual wording is has acted or is acting in ways that can lead to or has led to bodily harm to self, has behaved or is behaving violently, or is behaving or has threatened another person, or is threatening another person to fear bodily harm from him, has shown an inability to care for themselves that places them at the risk of harm because of the inability to. So that is basically neglect. So remember it as HSN, harm, self-harm, and neglect. You can expand it in words from there. So harm, self-harm of neglect is there or is possible, then you can you fulfill the criteria for supported admission. Then NR has to request. If there is no NR, then the mental health professional can appoint an NR and then report it to the mental health review board. So under this section also, you can only keep the person in a setting for maximum 30 days. And after that, you need to either discharge or admitted under section 90 or go into the independent admission. So remember that for independent admission, there is no fixed duration given. So you can keep an independent admission indefinitely, technically, in an MHCA. But if there is supported admission, there maximum 30 days, or you shift to section 90. And then again, you need to inform the board within 7 days for males and 3 days for females or minor. And capacity assessment has to be repeated every 7 days, which means that for in 30 days, you need to do capacity assessment at every week. And if there is capacity, then you again have to shift to independent admission. Now, the section 90, which is the supported admission, which extends beyond 30 days. So here, if under 89, there is more than 30 days, or if the patient is recently discharged in less than 7 days under this 89 section, then also this will be applicable. So here is the only difference, that here we need two psychiatrists fulfilling this, uh, authorizing this admission. And the criteria here is that the HSN criteria needs to be fulfilled consistently during this period, not just at the moment, but consistently. Admission is least restrictive and independent admission is not possible. Again, here needs to be informed in 7 and 3 days, and here capacity assessment is to be done at 15 days. You can extend it for 90 days, then 120, then 180 days. So under MHCA, the maximum possible admission for supported is 180 days, not more than that. So summarizing this, MHCA, independent or supported admission, independent admission, adult 86, minor 87, this one. So if a person is under supported admission, has been consistently showing criteria with harm, self-harm, neglect, then you can admit the patient beyond 30 days under section 90, but it has to be authorized by two psychiatrists. And where the patient is ineligible for independent admission and admission is least restrictive, so a rehab center or halfway home is not possible considering the status of the patient, then only you can apply 90. And here 90 again, this information to MHRB is same, 7 days and 3 days, but capacity assessment is much wider. You can do it every 15 days. Once section 90 is applied, you can keep the patient admitted for 90 days only. Then you need to reapply the section 90 to extend it to another 30 days. So that gives you 120 days. And then again, you can extend it to 180 days. So maximum you can double the section 90, not more than that. So now, so summarizing this, independent admission, adult 86, minor 87, adult patient can themselves request. Once one mental health professional or medical professional is sufficient to authorize. So authorization, application for minor, application by NR, and two psychiatrists or one psychiatrist plus medico-clinical psych MHP is sufficient. For supported admission up to 30 days 89, again application by NR, one psychiatrist plus mental health professional or RMP. Beyond 90 days, two psychiatrists is required. That is the difference. So 86, 87, 88 is discharge, 89 is supported, 90 is supported beyond 90 days. Within this section, there is this very important thing of for women and young children. Now, how such questions can be framed is that MHCA provisions for children and uh, women. So, what are the specific provisions in MHCA for children? So, this is a separate question that can be asked in a 5 or 10 marks question. And then you have to talk about admission by minor and special provisions for children, maternal separation, etc. So for this separation from mother is within the rights also we have discussed that equality and non-discrimination part. But apart from it, in admission, if the mother has mental illness, then you have to evaluate the risk of harm. If there is risk of harm to the child in postpartum psychosis, then you can keep a temporary separation, but the meetings, but you have to allow a meeting. You cannot completely separate the child. You can give supervised meetings to the mother, and then you have to reassess fortnightly and not extended beyond 30 days. So not more than a month you have can separate the uh, women from with young children. Now, the next part of admission, treatment, and discharge. We have talked about admission, supported independent discharge. The next sections are about absence, leave, etc. etc. So, leave has been mentioned in section 91. A person can, under section 87, 89, 90. So, supported admission also can apply for leave. So, it doesn't mean that if you have admitted a patient under support, they can't leave. They can apply for leave and no duration has been specified. But if a person absconds without application, without informing, then the role of mental health professional is to inform the police officer. The police takes into custody, protection, and sends back to mental health establishment. 93 is about transfer, which is if the court orders, the mental health review board orders to transfer the patient from one facility to another, then you can transfer it. Now, section 94 is an important section, and this can again be a short question. What are the provisions of emergency treatment in MHCA? So, in emergency treatment, apart from all of this, if a patient is uh, agitated in the community, then you don't need permission, you don't need consent so much. Any mental medical professional in hospital or even community setting can give emergency treatment if there is a risk of death, irreversible harm to the patient, or serious harm to others, or there is serious property damage. So, again, death, harm to self, harm to others, or property damage. So, in those four conditions, you can give emergency treatment, but this should be clear that this behavior is directly a result from the mental illness. If patients are, if two people have hit their cars and they are creating a ruckus on the road and trying to hit each other, you cannot inject them with haloperidol or phenarcoline. It has to be a result of a mental illness. Then only you can go ahead and give the treatment. And if an NR is there, then you can take the consent from them. If an NR is not there, that is also not required. And this includes physical, chemical restraint, and transportation duration. So in the ambulance, you can give the treatment, but you cannot give ECT, seclusion, surgery, or sterilization in the name of emergency treatment. You can't just take the patient to the facility and start. giving ECT directly that it's an emergency. No. And this emergency treatment duration is up to 72 hours. So if you are in a community setting or in a hospital setting and not at a mental health establishment, you can give the treatment for up to 3 days and then shift the patient to a mental health establishment. All right. Now, prohibited procedures are mentioned in section 95, and this includes direct ECT without anesthesia, muscle relaxant, ECT for minors, sterilization, or chaining in any manner is prohibited. So these are the four prohibited things: without anesthesia, for minors, sterilization, and chaining. Then 96 talks about psychosurgery, that consent of the patient is required, approval from MHRB is required. That this again is a very important thing, which is physical restraint. So the section number has been mismatched. Yes, so let me correct this is 97. So physical restraint section is that physical restraints are to be applied only when de-escalation and chemical restraints have failed, and if there is an imminent danger, and this has to be applied only for a duration as least as possible and not as a measure of punishment. Inform the NR and get a consent in 24 hours. If the NR is not there, you can use a physical restraint and get a consent in 24 hours. If a physical restraint is applied, you need to periodically check vitals and supervise the patient, and the mental health professional in charge should record it and then report it to MHR. So you cannot just restrain the patient forever, for a day, for 2 days. You need to record the exact time, record the vitals, record if consent is taken, record the need for the physical restraint, record that you tried chemical restraint, it was not effective, and for how long it was done. And you cannot do seclusion, or you cannot do chaining in any manner. Now, lastly, research. Research, again, only important thing is that PMI can give a free informed consent. If you want to research on this is schizophrenia with patient having lost capacity, then you need the state authority permission. You need the permission of SMHA to do that research. And only if the research is not possible on consent capable people and it is necessary for public mental health, person can withdraw at any time, except, and this consent is not required for case studies. For case studies, you can take uh, consent directly without SMHA approval, and NR can consent for research if capacity is lost. Now let's remember these final sections, uh, that are very, very important. So first are the admission and discharge related sections. Remember this, that I am MD, you are going to be MD, I am MD, and I supported extension. So I is independent admission, M minor, D discharge, supported, extended. So you can support extension. I am MD, and I support extension. So in 86, 87, 88, 89, 90. So that is there. Then the second is the late. So leave, absence, transfer, and emergency. 91, 2, 3, 4. So you're late. If you're late, you are on leave, you are absent, or you are transferred, or there was an emergency. There are only 4 reasons for getting late. leave, absence, transfer, or emergency. You are late there. And then the last is the PPRD. So what is prohibited? Direct ECT, ECT on minors, chaining and sterilization. What is prohibited? Psychosurgery, permission, restraint, and discharge planning. So not very important. We need to know about these two things importantly here. So IMMD support extension and late. So this would be sufficient to recall these numbers because this can be asked in your long case presentation. All right. Now finishing up the topic with a couple of more important things. The next is this topic where you can ask about, there is a question about responsibilities of other agencies. This chapter talks about you have done with the treatment, but are we talking just about care? Hey, medical care? We are talking about care in general. In general, care also talks about what is the role of police, judiciary, etc. So section 100 is for the dialing number for police. So it is the role of police officers. So for police officers, if they see a person wandering or believed to have mental illness who is at risk to himself or others. So if a person is wandering and staying on the roads, sleeping on the roads, but is able to feed himself and take care of himself, you cannot just take him into police protection and send him to MHCA. He has to be at a risk of harm to himself or others. So this thing of risk at harm to himself or others is a prominent feature across. So that you can remember. Then the police can inform the patient and or the NR and take to a public health establishment within 24 hours, where an assessment is done. If no mental illness is found, they can send it to a government establishment for homeless persons. And if there is a mental illness, then treatment has to be started. As simple as that. If a person with mental illness is ill treated or neglected at his home, and police suspect that, they cannot just barge in, they need the permission of the magistrate order. Similarly, uh, if a magistrate wants a person to be admitted, then they have to uh, give an order to admit him, but to a maximum of 90 days. And lastly, for prisoners with mental illness, the rule says that have you should not keep prisoners with mental illness in the general prison. There should be a psychiatry ward in the prison or sent to a mental health establishment with permission. And then the medical officer should report every 3 months that there is no prisoner. MHRB can visit it, and uh, PMI their report should be sent to MHRB at regular intervals. Similarly, custodial institutions should also be responsible for the care of person with mental illness in their facility. And this chapter is not very useful, not authorized under this act, should not be performed. Just some fine and penalties. Some places, if MCQs are there, then this can be important. So MHE without a registration, if you do not apply for provisional permanent registration, if first time you're fined for 5,000, then 50, 50, then 2 lakhs, 2, then 5 lakhs. 5, 50, 52, again 5. If serves, if you are serving at an MHE without registration, if you are after MD or going to an establishment and there where mental illness patients are being treated, uh, then if you are serving there and the place does not have a registration, then you are also liable up to 25,000. So after your MDs, be clear that you serve at the right place if your the law in your state is very strict. And if a person, any of the laws is contravened, then first time 10,000, 50,000, even uh, imprisonment is there. Lastly, this is the section number that you need to remember very explicitly, section 115. So this is a section that repealed the section 309 of IPC. Is that we'll go back just a minute. So in cases of severe stress, in case of attempt to suicide, it is presumed that it occurs because of severe stress, and the government's duty is to provide them care and assistance in case of the device is locked out. Just a minute. So sorry, what is NOVA? Leave of absence. MHCA does not mention any duration. So about the section 101 and 102, it mentions that for persons with mental illness in private residence, if the person is staying at a home and is subject to ill treatment or neglect at home, and the police see that the person is being discriminated or abused at home, then they can report the cases to magistrate. Magistrate can order to take the person into protection. And secondly, if the magistrate feels that this person needs an admission in mental health establishment, or for example, if a person in contradiction with law is requires an admission, then the magistrate can order the person to go to be put into a mental health establishment for a period of 10 days. Yes, yes, the recording will go. Till we are getting access. Uh, so till I get access to the screen. All right. Hello. Is everything okay now? Is the screen and audio okay? Yeah, so let's wrap it up. Yeah. So before I go into the final sections, just a few questions. Just put in the questions that we have not covered and have been asked in your institutes in respect to MHCA, so that we can cover those points. Just put in any of the questions that have been asked about MHCA here in the chat box, and we can cover it up uh, in the final few minutes. There is no space, Paridhi, there is no specific mention about duration of trying chemical restraint, physical restraint can be used. So generally, like what is the duration it becomes effective if you're giving IM or even IV? Usually maximum half an hour, there might be some effect. But if there is an imminent threat of danger, then you can restrain them in short time also. Halfway home, no, it does not come under 102. There's no specific section of that. Yes, yes, we'll come back to SMHA composition. Finally, we were into offenses. And lastly, section 115 that presumes that their attempt to suicide is a result of severe stress, and thereby section 309 of IPC is not valid now. It is not a criminal offense, and government has a duty to provide care, treatment, and rehab. This is very important. So now clinical practice, how it will impact it. So this is the portion that you need to mention when there is a note on MHCA and how it can be done. And apart from it, during practical, what you need to ideally tell when you are presenting a long case. So the basic assessment is uh, getting different now. We need to mention a diagnostic system as per MHCA, that okay, we have made a diagnosis of mental illness based on so and so criteria. That has to be clearly mentioned. The basic records need to be updated in terms of capacity, presence of advance directive or not, presence of nominated representative or not, and it has to be inquired beforehand itself. Capacity assessment is to be done whenever you are admitting a patient under supported admission. So that document, that page has to be there. Then OPD, IPD services again become different based on what is the criteria that you are admitting under. For all admission, you need sections and forms. Advance directive, you need to evaluate the validity that at the time of making the advance directive, was the patient fully understanding the conditions or not? If not, then you can report to the MHRB and that can be revoked. Nominated representative, you need to verify if he's willing, available, acting in best interest or not. For admission, not just the requirement for the clinical condition, but also if the admission criteria is fulfilled or not. For supported admission, HSN is there, right? So those are fulfilled or not. You need to inform the person with mental illness and nominated representative about each of these things, their diagnosis, their treatment plan, their rights to appeal, their rights to complain about the services, that you need to inform as per MHCA. The safety during hospital stay is to be ensured that it is their right to know about that. Information to the MHRB has to be sent in case of supported and minor admission. Record keeping has to be maintained and capacity reassessment has to be done. So those are the implications. Now coming to the critical appraisal of MHCA. So there are pros and cons. So there are a lot of pros, there are lots of cons, but I have summarized it in few points that is simple and easy to remember. So for positives, remember it as fair aid, that it is a very fair aid for persons with mental illness. First, it provides a framework for treatment and admission. So before that, there was no framework, who to admit, who to not admit, when it is uh, when it is appropriate or not, how is it diagnosable. So in framework, you can put points about the determination of mental illness. You can put points about various admission, treatment, discharge procedures. The second point is about autonomy. So autonomy, the patient gets autonomy. You can discuss about advance directive and nominated representative. Insurance, parity with medical insurance cannot deny it as a whole and soul. The rights based approach, which is the most important thing here. Then appropriate government duties have been mentioned in terms of police role, the role of magistrate, the role of budget allocation, the role of CMHA, SMHA. So all this has been, appropriate government duties have been mentioned. Integration with general health services, that we have shifted from mental hospitals to general hospital psychiatry units and Ayush units as well. And lastly, decriminalization of suicide is one of the most important positives of MHCA. So these are the major positive points of MHCA: fair aid, framework, autonomy, insurance coverage, rights-based approach, appropriate government duties, integration with general health services, and decriminalization of suicide. And for criticism, you can remember it as barriers. So what are the barriers in this? So bureaucratic burden, first and foremost, too much paperwork. Supposedly, if the patient is admitted for 1 month, you need to assess the capacity at every week. See the nominated representative, get their consent, document every physical restraint, inform the MHRB, send a letter, get their approval. If you want any city, get their approval in case of minor. So this is too much paperwork. So unnecessary burden on the mental health professionals. There are a lot of ambiguities. Ambiguities in the sense, as you have already asked, how long should we keep the chemical restraint? What is the limit? Capacity is a big ambiguity in itself. You have mentioned the definition, but what to exactly assess where it is not there? Advanced directives, you have mentioned that the patient should have capacity at the time of making an advanced directive. He should have information. But who is checking that? Who is checking whether the person has capacity or not? Yeah, it's not like a psychiatrist is sitting there when you are making an advanced directive. And there is no mention about covert medication. If a family wants to feed the person covert medication, this is one of the biggest drawbacks, one of the most used methods to treat patients who have lost capacity. Then resource constraints. You're talking about free medicines, free everything, whereas the healthcare budget is less than 2% of the total budget, and mental health care is much more down their line. Then with nominated representative, the role of family has reduced. That nominated representative stands tall about all the family members. So if a person has appointed one person as nominated representative, the rest of the family is has no say in the treatment. Then implementation gaps. So you are mentioning about free treatment, different child wards, different male female wards, halfway homes and rehab centers. Where is the infrastructure? Are they integrated? Can you send a patient admitted to a halfway home? Is there any ambulance facility? No. And then you're talking about rules, but rules are made by the state mental health authority. So it's different in each state. So the rules are also different. Then extreme complexities. So if you want to give the patient some covert medication, give the patient ECT, start the if the patient is in catatonia and everything, and you there is no nominated representative, you need to seek a permission from the MHRB, get a nominated representative, make the patient understand X, Y, Z, and then start. Too complex. As a result, doctors will be like the easy way out. Do the easy way out. And then there is a talk about rights. But what about tension? If the patient has the right that I don't want any treatment for bipolar disorder, I am happy in many, you are not sure about whether capacity is there or not. It is ambiguous term. What is the right way to treat? That is not there, particularly when we are talking about substance use. Then there is a big gray area. So these are the barriers: bureaucratic, ambiguous, resource constraints, role of family, implementation gaps, extreme complexities, defensive practice, and rights versus treatment tension. So those are the. Lastly, in a long question of MHCA, you can talk about recommendations. All of the barriers that were missing, implemented. So implementation, do a phased implementation. Funding was not there, give a dedicated funding. Procedures are too complex, make them simplified. So there is no integration, integrate it with primary care. There was no awareness about the rights, make people aware. Guidelines were different across places. There was no treatment tension, so make contextual guidelines, not broad guidelines. Those are the recommendations. So I think it's clear till now. Now let's take up the questions. Critically evaluate MHC. I think the last 2 points, last two slides are sufficient for that. Fair aid and barriers. Asked about substance use impact and addiction services under MHCM. So this is another gray area. So there is that addiction has been put as a mental illness in the definition itself, but then there are rules governing from NDPS and drug treatment centers separately, and then there is a lot of miscre differences between the same. We'll I'll try and cover that in the MA when we talk about the NDPS and other acts there itself. This is another question that is asked, particularly in practical, if you have a long case of addiction. But remember that in case of discrepancy, the MHCA will fall first into place. That is the broader rule. Yes, yes. So MHRBs are not very much functional across in state-wise. There are different. Uh, we don't follow capacity. Yes, you don't follow, that's true. But in case there is an examiner who comes up and who wants to hear that, then you should know what is the appropriate way as per MHCA. So you may routinely not say that, but have it at the back of your mind. Okay, this is the right way to do it. This is the procedure as per MHCA. Insight and capacity have no relation. Do not mix them. Capacity is an entirely different thing. Sometimes the patient can deny the illness, but because he has a rapport with you, he will agree to take medicines. So that's okay. So do not, there is no relation between insight and capacity. Capacity assessment is done by the only three principles: understand, appreciate the consequences, and communicate. Criminal responsibility, yes, another topic. Any other questions? Any other doubts? SMHA was remaining. Yes, yes. I'm just I can I think I can respond it in the group. That would be appropriate. SMHA composition is not usually asked. I'll respond to the group, checking it once again, so I don't miss any detail. I think that's the end of the presentation for now. I hope this was helpful. No, there is no rule. Child and adult has to be separate. There is no exceptions to that. These are just ways out that people do, but there is no separate writing that male child can be put in female ward. No. If you have any queries, tag me in the group so I can respond there. All right. Thank you. Welcome for staying. Thank you for staying for so long. All right. Bye bye. Good night. See you tomorrow. Dr. Millen will come in and we'll discuss about basic neurosciences part one, 3 days of basic neurosciences. Okay.